If you are having trouble because of thyroid eye disease, this video is just for you. Hi, I am Tomoyuki Kashima, the Hospital Director of Oculofacial Clinic Tokyo. Today, let me share with you different orbital approaches for exploration biopsy and tumor excision. First of all, please be noticed that I have no financial disclosure. Now, many oculoplastic doctors believe that the way of orbital decompression means the way of bone removal. There are 4 walls in the orbit: lateral, medial, floor and roof. Excision of any or all of them will result in decompression. Let me share my history here. Before and during my fellowship at UCLA, I used to prefer deep lateral wall decompression. I also did all walls including the medial, floor and roof. These bone decompressions sometimes are time-consuming due to hemorrhage and bring fear of fatal injury to the surgeon. Then, after my fellowship in the US, I visited Taiwan University and learned about orbital fat decompression from Professor Liao. And I now prefer orbital fat decompression. Fat decompression is the 5th wall decompression. He reported that diplopia occurred only in 2.8% of cases. Now, why do I now prefer orbital fat decompression? Fat decompression has 4 benefits compared with bone decompression. It results in a natural form, no skin scars and short recovery time, and the result is predictable and adjustable. However, there are so many muscles, nerves and vessels back in the orbit. Removing only fat sounds nearly impossible. How can we remove fat without damaging those important tissues? We always use a microscope for orbital fat decompression. Leica M320 is originally designed for dentists, but it is affordable and useful for performing oculoplastic surgeries as well. It costs about $30,000, which is 1/5 of the price of common microscopes for ophthalmologists. The microscope is necessary for orbital fat decompression, especially for the intraconal fat resection. And we also use spatulas, which are a good tool to go into the back of the orbit without damaging important tissue. There are 2 kinds of orbital fat. The first is the extraconal fat, which supports the eyeball and muscle cone. This is relatively hard and adheres to bones, tendons and muscles. Inside of the extraconal fat exists no important structure. So, we can remove this all. The second is the intraconal fat, which is the cushioning material for intraconal nerves and vessels during eye movement. It is very soft, loose and indefinite. The intraconal fat is related to important structures for the visual system. Therefore, removing this fat takes great caution. To avoid complications, we should understand those important structures. When we remove the orbital fat, we find muscles, nerves, and arteries in close proximity to the surgical site. Here, veins are ignorable, because the rupture of veins never damages visual function. First, how can we avoid damaging muscles? Muscles are relatively tough tissue and are the strongest among orbital tissues, making them difficult to damage. Using a spatula allows us to perform the surgery without harming the muscles. The orbit has 4 types of nerves: the optic nerve, sensory nerves, motor nerves of the extraocular muscles, and short ciliary nerves along with the ciliary ganglia. The optic nerve is most important for visual function, so damaging it is the last thing we want to cause. Since the sensory nerves play no role in visual function, we can relatively ignore them during the surgery. Therefore, during orbital decompression surgery, we must pay attention to 2 types of nerves: the motor nerves of the extraocular muscles and the short ciliary nerves along with the ciliary ganglia. The 4 rectus nerves are located in the optic nerve side of the rectus. We avoid the optic nerve side of muscles. We should avoid damaging the short posterior ciliary nerves and ciliary ganglia. The intraconal fat is soft, loose, and indefinite tissue. Therefore, we loosen the fat, avoiding tearing off the tiny fibers, which may be branches of the oculomotor nerve. The most important structures to consider when avoiding visual loss are the orbital vessels. Since veins are not directly related to visual function, we will focus only on the arteries. We need to examine the blood supply to the eyeball at the central retinal artery CIA and the posterior ciliary artery PCA. Which is more responsible for vision loss after orbital fat decompression? The central retinal artery CIA is close to the optic nerves. The rupture of the central retinal artery is possible but does not happen often. The rupture of the posterior cerebral artery PCA is more probable. It will cause anterior ischemic optic neuropathy AION. So, which area of orbital fat can be removed? This MI shows the image of the patient with thyroid eye disease. The orbital fat can be removed from 4 quadrants, avoiding the 4 rectus muscles. Additionally, fat can be removed just behind the lacrimal caruncle. The orbital fat in the lower quadrant can be accessed through the inferior fornix, while the fat in the upper quadrant can be removed through the upper eyelid. Now let me explain the basic concept of orbital fat decompression. First, the fat to be removed is deep in the equatorial part of the eyeball, because the anterior part of the orbital fat does not affect protrusion. Second, the deeper, the more effective. The cross-sectional area of the orbit changes depending on the position. Therefore, the removal of the fat deep in the eye socket is more effective, but also more dangerous. When we remove the extraconal fat with adequate knowledge of orbital anatomy, it is not difficult to do so. As for the intraconal fat, it requires great care. Using 2 spatulas, push aside 2 rectus muscles in each quadrant, then, the intraconal fat will pop out from the intermuscular septum. The fat should be loosened before removal. Intraconal fat contains tiny but important nerves and arteries, so its removal requires scrupulous attention. We have a video of the procedure on our YouTube channel. However, as it is a real recording of the operation, you may find it shocking or traumatizing. Please be careful when searching for and watching such content. This is the result of fat decompression. We performed both upper and lower fat decompression in this case. Before the surgery, the upper and lower eyelids were puffy and swollen. After the surgery, the eyelids have become thin. We can see the visage looks very natural. The second case is a 30-year-old woman. Thyroid eye disease made her look completely different. After 2 types of fat decompression, she returned to her old self. One of the advantages I would like to emphasize is that fat decompression can change the pupil distance. With thyroid eye disease, both eyes are spaced apart. By removing the fat right behind the lacrimal caruncle, where the eyeball normally is, the eyes come closer together. Thank you for watching to the end. We performed 4,000 oculoplastic surgeries last year. All of you are welcome to visit us. We want to help you with finding the best solution for you.